Ganeshaya Namah. And we start कि हमारा दिमाग सब कुछ, all the knowledge that we have, we are able to apply it correctly now. So it's a brainstorming panel discussion with case scenarios. Me and Monica are going to moderate it. Come this side. And we have our panelists. May I request them to come forward? Dr. Ishrat Zubair, Dr. Kea, Dr. Khushbu Dubey, Dr. Monica Pathak has opted out. She had an emergency. Dr. Payal Raghuvanshi, Dr. Pallavi Singh, Dr. Shalini Jain, Dr. Varsha Rani, and Dr. Jagriti Nagar. Please give them a mic. So I have been introduced in short. I would request my panelists, please give a two-line introduction of yourselves. Yes, ma'am. Please start.
The rest of the audience can come in front.
I'm Dr. Varsha Rani Chaudhary. I'm an assistant professor at GMC. Good morning, everyone. I'm Dr. Pallavi Singh, Bhopal and Unit.
Myself, Dr. Khushbu Dubey. I have done my senior residency from IMSCON Bhopal and present I'm maternity.
Okay.
I'm Dr. Shalini Jain from Raipur. I'm practicing by my own and I'm also AP at Balaji Medical College. And I'm the secretary of Raipur Menopause Society.
Hello, good afternoon. I'm Dr. Asha Jain. I'm Dr. Asha Jain and I'm practicing gynecologist at my own hospital.
Hi everyone, I'm Dr. Payal Raghuvanshi and I'm a practicing gynecologist and fertility expert at Nova IVF Fertility Center, Bhopal.
Thank you so much. Now, before I take the panel forward, I want to know, are any of you doing your sound? So, 3 people, 2 of you are not doing. So, are you doing advanced or you are doing just basic? You do vaginal, abdominal, what do you do? Or transperineal? So with this background, we proceed. Malhotra sir has already explained the adenomyosis and myometrial muscles, the endometrial stripe, the iota and ORADs has been explained by Gokhale sir. So this is what I want everybody to remember, that neovascularization means new vessels. And what is abnormal about these vessels? The resistance is very low. So they have low resistance, they leak easily, and critical cutoffs, resistance index less than 0.4, PI less than 1 are suspicious for malignancy. Color scoring, 1 is no flow, 2 is minimal, 3 is moderate, and 4 is chaotic flow. And 4 is usually associated with malignancy. Knobology is Kuldeep sir's favorite topic. Knobology. So, Doppler has a beautiful language, but you need to be able to speak it. You can only speak if your knob settings are correct. If your PRF on a low resistance vessel is very high, what is PRF? It is pulse repetition frequency. What does it actually tell you? It tells you what is the flow. Now, if the flow is high, it's a wide vessel, you need to keep the PRF high. If it is a slow flow in a small vessel, thin vessel, you need to keep the PRF low. And wall filter has to be kept minimum for low flow vessels. And power Doppler, now in machines, you also have it HD and you have it color. Dr. Mansi has shown which is not showing the direction of flow. But now machines also show the direction. So usually the setting is red towards the probe and blue away from the probe. We can adjust it as per our wish, but this is the basic thing that you have to remember when we are going to start our cases. So the first case is a 49-year-old with heavy menstrual bleeding. She is feeling pressure on her abdomen, कुछ भारी भारी लगता है. When you examine her, the globular uterine enlargement is there. The length of the uterus is more than 12 centimeters. There is asymmetrical thickening of the myometrium, and you can see intramyometrisis and Venetian blind shadowing. Okay? So what comes to your head? You've done a PD and you find that the uterus is globular. What do you think? You think it is adenomyosis, right? How do you confirm it? And what is this Venetian blind shadowing? This is the image.
Moving from endometrium towards the myometrium.
And you have, what are the other findings? Malhotra sir just told you about them. And see, you are all gynecologists, you are all very senior. My job here is to confuse you. Okay? That is how we are going to make fun out of this panel. So tell me, you say that adenomyosis, here the vessels are crossing the EMG. In an endometrium which is ready for fertilization, even after that, you will have vessels that cross the endometrium. What is the difference?
Those patterns will be, very uniform. But in adenomyosis, these patterns are not uniform, and there will be disruption of the zone.
And the endomyometrial junction will also be disturbed in adenomyosis cases. If we have to confirm adenomyosis according to Musa criteria, we'll see, and most of the time we differentiate it from
The endomyometrial junction is seen on what? A 2D, a 3D, a Doppler, what do you see it in?
first in a 2D,
In all
and then
things we can
we can confirm it on 3D as well.
But it cannot be confirmed on Doppler.
Doppler.
Unless Doppler, you've done the glass body view and you have the outline of the uterus and everything, and change the transparency setting so that you can see the uterus in the background and then you can see the blood vessels. Without that, so for EMJ, it has to be 2D or 3D. Right? So look at these images carefully and we will proceed to the questions. One by one you can take the questions, right? First, second, third, fourth, that way. So the first question, what is the most specific endometrial sign?
It is presence of subendometric cysts.
What are subendometrial cysts?
These are small cystic spaces we can see around endometrium, which is
What do they indicate? These subendometrial cysts, what do they actually say to us? I have given the answers, but it's your job to actually explain why it is being seen.
What is the structure which is causing the cyst to form?
The glandular structure in the endometrium, the myometrium is forming these cysts.
What?
The glandular structure.
So the endometrium getting into the gland,
Yes.
and then during menstruation bleeding.
There is a collection.
Okay. Now there is adenomyosis, there is bleeding. Does it cause mass effect on the endometrium?
Not very much because it is a uniform enlargement.
Exactly. But is adenomyosis always uniform?
No, it can be both.
It can be local, it can be focal,
Yes.
right? It can be global.
If you compare the anterior and the posterior wall of the uterus, where does adenomyosis usually begin?
Posterior.
It's the posterior.
It starts from the posterior wall. So
Eventually there
this is
is-
where when you take the correct LS view, you have to measure both walls.
Yes.
The thickness of both walls. What is a question mark sign?
It is the posterior displacement of the uterus and fundus is flexed back.
The endometrium is folded. The endometrium makes a sign
it starts in the posterior wall thickens, and that is what is causing the stretching. Then, does it regress after menopause? Adenomyosis, does it regress after
Because it is estrogen dependent, so it regresses. Usually, but in few patients it may persist.
It does regress. It does regress.
Yes.
Over years, it does regress. Okay, because it is estrogen dependent. Can it mimic malignancy?
Yes. Large in size and
How will you differentiate?
in malignancy we can see the central necrosis.
See, in adenomyosis, you have the endometrium getting into the uterine wall. Malignancy also the same.
The doctor also we can see
The Doppler pattern.
We can differentiate by doctors.
It enters the lesion at 90 degree radial flow in adenomyosis.
Okay. So one more thing is, what is the rain shower appearance or the Venetian blind appearance?
These are the echogenic striations which are moving from the endometrium towards the myometrial state. Fan-shaped.
They are because of shadow.
Yes.
They are basically shadow.
Shadow.
Because there is an ecogenic area which the ultrasound waves cannot penetrate.
Exactly.
And behind that you get a shadow.
Exactly.
Madam Asha ma'am, I would like to ask you a question. Give us, maybe ma'am, still, what are the definite diagnostic criteria differentiating the adenomyosis from malignancy? This take-home message is important because
We'll come to that.
yes. I'll just give you a little example. Of course, now I'm menopausal, but perimenopausal years, last 6 months before menopause, I started having menorrhagia. So I went to Dr. Supriya Mishwari for a TBS, and I had a huge, a significant adenomyoma sitting on the fundal region. It was a very strange appearance. Then after 6 months, I had menopause. Again, a repeat scan, the uterus had completely become normal.
Because of the
So how do
fluctuations of the hormonal
you differentiate it from a fibroid?
It is at presence of
Fibroid.
Supposing there is a localized adenomyoma and there is a fibroid.
Fibroids will be having, capsule, and the blood supply of the Doppler supply of the fibroid will be different. And in adenomyosis, Doppler
One by one. It's your turn.
Presence of a capsule, then the vascularity will be peripheral, and in adenomyosis it will be radial.
You have a basket of blood vessels in a fibroid, which you do not have. You have intralesional flow. You have intralesional flow in adenomyosis. What is the junctional zone cutoff on MRI? Around 12, 10 to 12. Mansi is here. Need your help. What is the junctional zone cutoff on MRI?
For adenomyosis.
Usually what we take is more than 8 to 10 mm.
Okay, so the guideline says 12 mm. Does it regress after menopause? Yes. Have I missed some questions?
No, actually,
Yes. Is CA 125 elevated?
Yes, it is.
Around 100 and less than 100.
Usually it will be less than 100. Can it be more than 100?
Yes.
When? Which is the specific condition where it is not malignant and still you have, when it is associated with endometriosis and you have intraperitoneal bleed.
And there are very many cases where you will see adenomyosis concurrent with bilateral endometriosis. Especially our fertility specialists will agree.
Can it be treated with the Mirena?
Yes.
If it is a globular,
If it is uniform, globular,
If
not distorting the cavity.
if the uterine cavity is not distorted. So that is the basic question. If the cavity is not distorted, you can put in a Mirena.
Madam, can you put a Mirena in a question mark uterus?
What did I say just now?
if it
If the cavity is not distorted, okay, so what are the pitfalls? You see a big uterus and you see the endometrium and you think it is adenomyosis. Can you endometrial CA?
We miss the junction.
If you miss the junctional zone, if you don't scan from one end to the other, you've taken just one view and you've seen it and you've measured it, but you've not walked through the entire uterus, left to right, top to bottom, you will have chances of missing and malignancy. So always assess the endometrium separately and the myometrium separately. Don't put them two together. Dr. Narain sir has just explained the MUSA and the AITA. And now most machines have it. Most machines have it. Anyone here, though everybody looks quite senior, but anyone who's buying a new machine, when you are ordering a new machine, ask them what all is available and see that you tick that I want this open. Otherwise, they'll charge you like 3 lakhs, 4 lakhs to open that software. So when you're buying, always tick that yes, if this is available on the machine, AITA is there, IOTA is there, MUSA is there, I want it all operative on my machine. Remember this, and this is something you need to spread to the people, because how do companies make money? The primary sale doesn't make money. It is the service, and the additional is when you're working, you find ye nahi chal raha, then you say कि चालू करो, फिर वो आपसे पैसा लेते हैं. 1 लाख में कुछ नहीं. No, it is 3 lakhs.
3 to 5.
Per software.
They charge.
Yes, per software it is 2.5 to 3 lakhs depending on
That's
what
why
you
I put
want.
that message. You are still to answer me that.
And there are certain brands which charge higher,
Higher.
certain
Per
lower.
package they are adding it. Per software.
Per bit of software. Per bit of software, because measurement is already there. Just adding the interpretation, they will charge you that much.
Dr. Mansi, yeah, you.
नहीं वो
They are
मशीन
charging
का
that
नहीं
much.
हो सकता, वो तो जिसको जो खरीदनी खरीदा. वो जंक्शन से उनने बोली थी कोई 8 to 10 mm मैंने एक बार चेक भी किया 8 to 10 mm जो हम लेते हैं ना वो उधर से चालू होता है, but more जैसे strongly suggestive and borderline, more than 12 mm is strong.
Strong.
8 to
That
10
is what-
beyond you should
Yeah,
start
yeah,
thinking.
yeah.
So now we come to the tamoxifen endometrium. Sir has also explained this in detail, Naren Malhotra sir. I hope you all listen carefully, because again we are going to confuse you. Alright? So there is a
Don't pay
60-year-old
for
on
software.
tamoxifen for 4 years.
Don't pay for software, it is freely available, these calculators.
Sir, that Adnex and all is available. But to have it on your machine, you have to pay.
You have a laptop just inside your machine.
मैम वो
You
इतना
can-
काम
don't
कर
have
रही
to
हूँ,
pay
मेरे
so
पास
much.
सब कुछ है, fully loaded है, but ना
मैं आपसे बोल रही हूँ कि जो भी मशीन खरीद रहा है ना, आपको क्या दिक्कत है?
पहले से
आप
डाल दो।
पहले से
पहले से
खुलवा
बोल
लो।
दो, पहले से खुलवा दो।
पहले से खुलवा लो. See, in my machine, I had the contrast, I had the hypocene, and I had clicked it. The elastography, the contrast, the hypocene, वो देते ही नहीं थे. मैंने 2 साल तक लिखा पढ़ी करी that when I had already done it, you have to, because hypocene even images you cannot see unless that software is activated. So when you are buying a machine, be alert, buddhu nahi banna. And now we come to the next thing. A 60-year-old on tamoxifen, what does being on tamoxifen indicate?
Breast cancer.
She is a breast cancer. Do today we give tamoxifen? We now usually give letrozole, but tamoxifen is still given in certain cancers. So there is a Swiss cheese appearance of the endometrium, which is 18 mm thick. What cutoff did Naren sir tell you?
More than 20.
Around 40.
That also you might think of it. You might think of it, but otherwise not.
No.
And it's
So
asymptomatic.
what is the cutoff?
Sir said more than 20 to 21.
Nice. I was chairing that session and I was listening.
60 years है ना, तो 18 mm we should investigate.
Swiss cheese appearance of the endometrium, and there is subendometrial cystic change. You've done a saline infusion sonography. What do you see? So there is the polyp, right? Is it common with tamoxifen?
Yes.
It is common with tamoxifen. Before I go to the panel questions. How do you differentiate a malignant from a benign polyp?
Color of single vessels.
Multiple feeder.
On a 2D, what will you see? On a 3D, what will you see?
Continuation margins, and the polyp regularity.
The surface of the polyp, that is very, very important. The number of polyps, the surface of the polyps, how their origin is, you know, and then
Multiple feeder.
you go to point number 2, and point number 2 is the Doppler. What do you see in Doppler? A benign polyp will usually have a single feeder vessel.
Single on at the most 2. One or two. Multiple.
Will have multiple, and what means we've been talking about chaotic, but what does it mean?
There's no pattern.
Branching,
Abundant flow, the diameter of the vessels are also different. The direction of the vessels are also different.
Ma'am, as it progresses further, no, ma'am. As it progresses further, chaotic का ये है कि वो पतले होने की बजाय और मोटा हो जाएगा.
So the basic thing that sir has said, and what I want to tell you, you cannot see the vessel originating. You just see bursts of color. That is chaotic flow. In a normal vasculature, you'll see the peripheral round of the vessels, then the vertical vessels, then the branching. But when it is a chaotic flow, the pattern is lost and vessels appear de novo. You don't know where they are coming from. They are de novo vessels. So that is what has to be very clear. And for a saline infusion, it's not a big deal. It's very, very, very simple. Infant feeding tube inserted. Infant feeding tube in the uterus. जो घुस जाए, atrophic uterus है ना? We are talking of post-menopause. It's an atrophic uterus. What I do is, when I know I'm going to do it, sometimes I'll put a 25 milligram of misoprostol. फिर 1 घंटे बाद I'll put that cannula. It will go, and then you put in the saline, and you can see very easily. All right. So, what are the contraindications of saline infusion sonography?
Suspecting
Infection.
abnormal undiagnosed bleeding, suspecting malignancy.
So, if you suspect malignancy, you will not do it. If there is pus inside, now how will you identify pus? बोल दिया हमने biometric, but how do you identify pus?
Echo pattern and symptoms.
What is the echogenicity? See, clear fluid is anechoic, means it has no echoes, it is black. Now in that black you can have flakes, floaters like, or you can have it really thick and hyperechoic. So then you have to be alert. It could be blood, it could be pus, and ultrasound cannot tell you कि ये blood है कि pus है. Another thing is, then you see the vasculature, margins and vasculature. What happens in inflammation and what happens in malignancy? Yes, but see, and inflammation will not have chaotic vessels. The pattern will be maintained. There will be new vasculature, but the pattern will not be disturbed. Whereas in a malignancy, the pattern is disturbed.
Smooth collection, margins collection will be smooth margins. If it is not.
Not necessary.
No.
Long-standing infection, you get a problem. So, is tamoxifen an estrogen agonist or antagonist in the uterus?
In the uterus, partially agonist.
In the endometrium, it has got more of agonistic action. That is why it causes hyperplasia. That is action. Does thickness of the endometrium correlate with cancer risk in asymptomatic patients?
No, mostly 20% of the cases, the polyps are there. The malignancy is less than 1%. So it does not correlate with the thickness. And most of the time, in 12 to 15% cases, we'll get the cystic glandular glandular hyperplasia. So it does not correlate.
And how much time duration after stopping tamoxifen these changes go?
They take mostly 1 year to 18 months to regress.
So what causes the Swiss cheese appearance? Can you describe on ultrasound how will you won't write Swiss cheese, you'll also describe the lesion. So how do you describe a Swiss cheese appearance?
It's like a cystic appearance, mostly honeycomb.
The cysts are unequal in size. You know, they'll be small, large, like when you cut a cube of Swiss cheese, you will see multiple cysts. Those are because of the yeast and the fermentation. Here it is because of this. So the histopathological diagnosis is cystic and cystic.
I had a patient who was referred to me from Manipal Hospital, Bangalore. She was on tamoxifen and her endometrium was 25 mm in size. And I went ahead, did a DLC and got nothing. Got nothing at all. Hysteroscopy also got nothing. So let us not just go by
Books.
the appearance, because in post-menopause I had another patient who had an endometrium which was like 3 to 4 mm, but she would just go on bleeding. She was 67, diabetic, hypertensive and obese. So we went ahead and did a cytology of her endometrium because we got nothing, कुछ भी नहीं मिला, सक्शन में कुछ नहीं मिला, थोड़ा फिर फ्लूइड डाल के लिया, and she had endometrial cancer and the variety was such that we lost her in 3 months और कुछ भी नहीं मिला था. So let us, we do a really great job, but let us not be overconfident because it's always lesions will cheat us many a time. So whenever you are interpreting, whenever you are writing, be careful about what you are going to recommend on that. Right?
So Madam, first you have written when should we biopsy. If you biopsy only when there is bleeding, then you also biopsy for the histopathology, no?
Biopsy means histopathology. But in tamoxifen cases, you only biopsy if there is bleeding. Not on basis of thickness. That's what I told you. It looked 25 mm and there was nothing.
Even if it is like you said, ma'am, 25 mm, you did a biopsy. Even if like it is 25 mm, we should wait for a bleeding to occur to get a
For tamoxifen. For tamoxifen. Not for anything else. What is the pedicle artery sign? Why is ultrasound often an overestimate here?
Because the cystic glandular hyperplasia and the vascularization, we assume that it looks more like a malignant.
But it is mostly subendometrial.
Yes.
The change also involves the myometrial part and the stromal part. So it appears that it is a thickness of endometrium, but it involves the
Actually, it is myometrial cysts which are confused with endometrial cysts. So that is why the overall appearance looks thick, and that is the explanation of why I got nothing. Because endometrium was normal, it was thin. It was myometrial cysts that were giving that 25 mm thickness. Because ultimately ultrasound is sound waves and measuring solid and liquid. That's it. So
we heard Mansi telling us that MRI is an expensive option. Here, what is the role of MRI in such cases? Women taking tamoxifen with a hypoplastic endometrium. Would you consider MRI?
We won't consider MRI directly if the patient is asymptomatic.
Yeah.
Given biopsy.
So do MRI, do not do it or advise it unless you are having a suspicion of malignancy. And SIS, of course, Madam has given us the clue the way how to do it. Most of us in gynec practice are reluctant, let's go to the next is, but fluid inside the endometrium can give you wealth of visual information, which cannot be obtained otherwise. Because basically you want to differentiate the tissues one from the other. and the best media is fluid, so that's I think we should start doing. A good tip is to insert 25 microgram of mesoprostol tablet 1 hour before your planned procedure. So does the risk of cancer increase with the duration of use of tamoxifen?
Yes.
If it is long duration.
Yeah, and the most common finding is of course you get multiple endometrial polyps.
Ma'am, can I just add a little bit of
Yes,
a
sir,
point
yes,
here?
sir.
The thing is we have to start zooming in our image much more because we just have a small picture out there and we tend to measure the
Sir,
endometrium.
actually that is why we do a transvaginal, we zoom, and that zoom image is what we should have. Mostly when radiologists do the scans, there is no zoom. You see, take one, itna bada, there are 12 images on one page and the uterus is this big and the rest is black space and the bladder. So, for gynecologists, we are used to looking at the uterus. Use zoom, use depth, it is your friend.
Actually, that is the reason we started doing it.
And,
Yeah.
and second thing is, ma'am, we have to start using 3D and measure the endometrial volume, just not the thickness, bivocal.
Yes.
That is always there.
But again, sir, it has to be, you cannot differentiate myometrial cyst from endometrial cyst in the post-menopause. So that will always be, in tamoxifen cases, that will be a problem. And for tamoxifen, the learning point is that for us clinicians, bleeding is the primary trigger for intervention. If there is bleeding, intervene. If in doubt, do a saline sonography. Now, a simple cyst.
This is a 65-year-old woman with a 5 centimeter pure cystic mass found on KUB scan for kidney stones. So an incidental diagnosis. The mass appears thin-walled, unilocular, no solid component, no ascites, completely asymptomatic woman.
Means she came for pain abdomen. तभी तो उसका stone के लिए ढूंढा.
So there is a typical appearance, a sonographic sign present here which Dr. Kuldeep Singh taught us about. What is it?
I want
telling
one of
us?
you to describe this.
Describe this lesion.
According to Ayurveda,
Describe this lesion, what you can see here.
it is uninocculated, thin-walled, and the wall is regular, posterior smooth structure, posterior acoustic shadow.
Enhancement.
Is there shadowing? Please, is it shadowing or is it enhancement? What is the difference? I want, see, I learned sonography with great effort because I am a gynecologist. So I know kahan pe galti hoti hai. That's why I am asking those questions. What is the difference between enhancement and shadowing?
Enhancement is the hyperechogenic structure seen beyond any cystic structure, and shadowing is the hyperechoic structure. Hypoechoic that is seen due to some solid lesion.
So basically what it is saying is, what a cyst that is empty. The sound waves travel faster in liquid compared to solid. So sound waves are going across and you are getting a nice hyperechoic area. But when there is a solid, it is an obstruction and sound waves cannot penetrate. Behind that there is a shadow. So always a pitfall, if there is a big solid area, you don't know what is behind it. So you cannot comment on the area that is covered in the shadow. Try to look at it from different angles, but if there is a shadow which is not allowing you to see beyond, you need to write clearly and offer for an MRI, because beyond the shadow you can't see.
You can't see, that's what it occurs in
I learned
all the malignant
about
cases.
acoustic shadowing is best learned. You just try to scan the liver of the patient, and if you spot a gallbladder with a calculus, that gallbladder calculus gives a very nice acoustic shadow. Once you see that image again and again, you can extend it to all your gynecology.
And behind the femur,
Yes,
you're going to be
everything,
looking at.
everything.
All bones when we are doing it.
In all the cases of malignancies or dermoid, you will get in the shadow and it will represent the lesion is tip of the iceberg.
I did
So,
not actually
yes.
show you the simple rules because they had been shown by Sir. But acoustic shadowing is a feature of benign.
Yeah.
Simple. So now what is the ORAD score? So risk of malignancy less than 1%. Do you want to do a CA 125? 3 centimeter cyst you want to do? What is the cutoff where you want to go on investigating in post-menopause?
If it is more in size, if it is increasing.
What is that size?
3 centimeters.
3 cc. 3 cc.
Cubic. Volume.
3 centimeter cube. I could not write that.
Yes, cubic.
3 centimeter cube.
Volume.
3 ऊपर नहीं चढ़ा मुझसे. बहुत बार लिख के फिर मैंने मिटा दिया.
ML लिख दीजिए करिए मैम, that's the best.
ML.
Means I kept trying and then I just left it.
Even I couldn't do it, but my staff does it, so they know how. I have also forgotten in that.
That's a shortcut.
So when can we stop following it?
After 1 year.
It is not increasing in size, it is not increasing in size, not changing.
If there is a septation, a thin septation, does it change the diagnosis?
No. Thin septation with no vascularity. We'll have to look for the vascularity and other things.
Then how can there be no vascularity? Tell me, when do you actually visualize vessels?
Yes.
There can be a lot of blood vessels and you may not be able to see them. Uterine artery भी नहीं दिखेगी. कब? Either your PRF is wrong or the direction of your waves is wrong. So you cannot say कि ये इसका septum है. वो septum आया तो जिंदा tissue है ना? There has to be blood.
PRF setting हमने 0.3 या 0.6 ही रखा है ना मैडम उसमें.
Now, आप power NG use कर लो मैम.
filter और setting
Power
पहले.
NG does not require angle back.
So use power end. ठीक?
So it's a very powerful message of today's workshop. Start using your PD and power engine.
For all
What
this power
happens is, it is now ORADS 3. ठीक है? If you see a septum, a simple cyst is ORADS 2. With a septum, it becomes ORADS 3. Now it is only 3 centimeter, right? Now if it becomes 11 centimeter, no other change, only the size has. It remains ORADS 3.
ORAD 3 but upgradation.
Is laparoscopy indicated in this case?
If it is simple cyst, not much. If patient is symptomatic, then we can do. If patient is symptomatic, any twisting, any pain, risk of torsion. If it is symptomatic, any pain.
Does BMI affect the ultrasound accuracy?
Yes.
What is the limitation of ultrasound vaginally?
Fixed uterus if it is like
Mid position, not anteverted. Anteverted बहुत अच्छा दिखेगा. Mid position
the
uterus.
fixed like previous scar uterus which are fixed to the anterior abdominal wall. There is a
Whatever. If there is an angle, you will be able to see it. It is only when it is वो खड़ा होता है ना.
mid position, yes.
Poor
Chest
penetration.
section.
Poor penetration, you will not be able to see the fundus of an enlargement, especially mid position.
The pitfall is that you label it as a complex mass just because it's large. And simple means pure anechoic with a smooth wall, size is secondary, no septa. No septa. If there is a septa, ORAD's grade goes. इसको फट से कर
कर
लो.
लो.
इसको कर लें?
Fast will do it fast.
Okay, 55-year-old, 4 centimeter cyst. It has a 4 mm bump on the wall. 4 mm. Findings are a solid papillary projection of 3 mm with internal vascularity. Diagnosis? Diagnosis? So here you can see high magnification zoom जो सर बोल रहे थे. Irregular height. Can you see the vessel supplying it? So it has internal flow. अब एक एक सेंटेंस में Three or more. Three or more. Three or more. Okay. In the adnex model, what is the cutoff? In the adnex model, what is the cutoff for capillary projection? It is 7 mm. Okay, it is 7 mm. So ORAD score here is 4. Malignancy risk. You want to use power Doppler? In the image we have used power Doppler. Why?
Because the sensitivity for power Doppler is better than the
Can you take spectral Doppler in a power Doppler?
Yes.
Yes. So how much RI is suspicious? Does the age of the patient increase the score? Yes. Menopausal status. Menopausal status will increase the iota status in the adnex model. Age. No.
Age is not important.
Age post-menopausal status. How do you differentiate a clot from a solid projection?
Vascularity. That's the margin. Vascularity.
Exactly.
And concave margin. Retracting sort of.
MRI needed?
Yes. Yes, ma'am. Yes, yes. Yes.
Okay. Simple. इसमें simple rules use होगा? Iota simple rules? Yes. Okay. And solid components, what is the take home sign? Is there shadowing? Is there acoustic shadowing in these images?
There is acoustic shadowing.
There is no acoustic shadowing. It is the angle. Do you remember fibroid के अंदर जो आपको साइड में angular मिलता है क्योंकि वहाँ penetration है. So that has to be not confused with.
This anechoic content, there should be some acoustic.
No, depends. The wall is always solid. उसके beyond तो आपको वो दिखेगा. So the take-home points for this panel: don't over-manage simple cysts. In post-menopause, a simple cyst less than 3 cm is essentially physiological. Shadowing is reassuring. Acoustic shadows in the solid mass usually point to a benign fibroma or a tumor. Okay? And use the zoom. Always magnify the internal wall of any cyst to search for a tiny papillary projections which are more than 3 mm in height.
If there is a malignancy which is causing a solid mass, ma'am.
If there is a base when I wanted to ask.
Yeah, same question, na? If there is a malignant nodule which is solid, that will also cause shadowing.
A malignant nodule does not cause shadowing.
Why, ma'am?
It doesn't cause shadowing.
But if it is solid, ma'am.
It is solid but it doesn't cause shadowing. Sir, अभी यही थे. Gurdeep sir,
Sorry, ma'am.
just need your help, sir.
जी ma'am.
Acoustic shadowing not seen in a solid nodule in a malignancy. Why?
Because when it is going to be very, very hypericoid, like a bone chip which has नहीं आ रही, it is not necessarily that all solid nodules will have shadow. Not at all. But the thing is, if there is a solid nodule which has shadowing, we think more of a dermoid. If there is a solid nodule which has vascularity, we think more of malignancy. Always. In a post-menopause.
So acoustic shadowing in the simple iota rules is a
Good side. Is a
benign
B marker. B marker.